Hello and welcome to the topic X-linked conditions in the module Clinical Genetics. Here we will be looking at X-linked recessive conditions such as Kallmann syndrome and Fabry's disease, as well as X-linked dominant conditions such as vitamin D resistant rickets. Let's get started. X-linked recessive disorders. In these conditions, the abnormal gene is carried on the X chromosome and the carrier female, the normal allele on her X chromosome, protects her from the disease. Since the male does not have this protection, he will manifest the disease. X-linked recessive disorders are transmitted by heterozygote females, which are carriers, and male-to-male transmission is not seen. Affected males can only have unaffected sons and carrier daughters. 50% of female children are carriers and 50% of male children are affected. The following conditions are inherited in an X-linked recessive fashion: androgen insensitivity syndrome, Hunter's disease, Becker's muscular dystrophy, Duchenne's muscular dystrophy, Lesch-Nyhan syndrome, color blindness, nephrogenic diabetes insipidus, ocular albinism, Fabry's disease, retinitis pigmentosa, G6PD deficiency and hemophilia A and B, Wiskott-Aldrich syndrome, and Fragile X syndrome. Let's look at the first disorder, which is Kallmann syndrome. Kallmann syndrome is a recognized cause of delayed puberty secondary to hypogonadotropic hypogonadism. It is usually inherited as an X-linked recessive trait caused by the failure of GnRH secreting neurons to migrate to the hypothalamus, leading to gonadotrophin releasing hormone deficiency. This may arise due to the abnormalities of KAL1 and KAL2 gene abnormalities. Among the features seen are low LH and FSH levels, lack of development of secondary sexual characteristics causing primary amenorrhea, cryptorchidism, which is more suggestive of Kallmann's than Klinefelter syndrome, anosmia, which is the lack of sense of smell due to the failure of the olfactory bulb to develop, leading to loss of gonadotropin releasing hormones, cleft lip or palate, color blindness and deafness. There is no mental retardation seen in Kallmann syndrome, and patients are typically of normal or above average height. The diagnostic tests for Kallmann syndrome include fluorescent in situ hybridization, which is currently the best means of a genetic diagnosis. Absent olfactory bulbs are present on 75% of MRI scans in these patients. Treatment would include pulsed and not continuous GnRH treatment, which is needed to restore LH and FSH release. Once family is complete, one may switch to testosterone therapy, which may be convenient for the male. HCG and FSH as well as harvesting eggs and in vitro fertilization are offered for women who want to start their family. Fabry's disease. Fabry's disease is an X-linked recessive lysosomal storage disorder characterized by myelin deposits in tubular epithelium and vascular endothelium, resulting in ischemic nephropathy. The molecular defect is a deficiency of alpha-galactosidase A. The affected lysosomal enzyme alpha-galactosidase A converts trihexosyl ceramide to lactosyl ceramide. Accumulation of trihexosyl ceramide in the endothelial smooth muscle cells of blood vessels causes ischemia and infarction, particularly in the kidneys, which explains the elevated urea and creatinine levels and presence of proteinuria. The disorder has three distinct clinical features, which are classical presentation in the male homozygote with early presentation in childhood, presenting with angiokeratomas, heart failure and renal disease, male homozygotes with atypical presentation in childhood, which are proteinuria, acroparesthesia, angiokeratomas, and cardiomegaly. And finally, female heterozygotes which present again in adulthood with mild similar symptoms. The diagnosis is confirmed by demonstration of absence or deficient levels of alpha-galactosidase A in leukocytes, plasma, or cultured fibroblasts. The most efficient means of diagnosis is by slit lamp examination of the cornea, which reveals microscopic lipid deposits. X-linked dominant disorders, on the other hand. The gene responsible for a genetic disorder is located on the X chromosome, and only one copy of the allele is sufficient to cause the disorder when inherited from a parent who has the disorder. Males can only get an X chromosome from their mother, whilst females get an X chromosome from both parents. As a result, females tend to show higher prevalence of X-linked dominant disorders because they have more of a chance to inherit a faulty X chromosome. When the mother alone is the carrier, she herself will have the disorder. 50% of her daughters and sons will have the disorder, and 50% will be unaffected. Affected females will transmit the condition to 50% of their children, whether male or female. When the father alone is the carrier of a defective gene associated with the disorder, he too will have the disorder. 100% of his daughters will have the disorder since all his daughters will receive one copy of his single X chromosome. None of his sons will have the disorder as sons do not receive an X chromosome from their father. Example of condition is vitamin D resistant rickets. It is an X-linked dominant condition. Affected female will transmit the disease to 50% of their sons and 50% of their daughters. Affected male will transmit the condition to all his daughters but none of his sons. They usually present in infancy with failure to thrive and caused by impaired phosphate reabsorption in the renal tubules. So as mentioned, there would be failure to thrive, normal serum calcium, however low phosphate and elevated alkaline phosphatase levels. X-ray changes may include cupped metaphysis with widening of the epiphysis. Diagnosis is made by demonstrating increased urinary phosphate levels, and the management is with high-dose vitamin D supplements and oral phosphate supplements. We have come to the end of this topic. Thank you.